Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. We're very pleased this evening to have Dr. Ross Hauser return with a presentation on 10 low-cost ways to improve symptoms of peripheral joint and spinal instabilities from hypermobile EDS, including brain fog, pain, POTS, mast cell activation, and more. Before we introduce our speaker, we'd like to give a brief overview of our free programs for those attending for the first time. So we'll discuss who we are, what are our programs, introduce our speaker, and do a Q&A. Again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter Deanna was diagnosed with hypermobile EDS in 2008. The same year, my wife Carol passed away from breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our programs at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We have been sponsor for many conferences and EDS events. We started or supported over 125 support groups to date. Each group is given their own free website with a link from the directory and map. In 2019, we presented a program to help leaders organize and manage their support groups in Facebook. Mandy Harvey was guest speaker for that program that was web streamed, recorded, and posted on leadeds.com. We received feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We had produced over 120 webinars that can be searched by presenter's name, topic, and location. Our healthcare providers educational program was introduced in September 2017. It provides free continuing education credits for healthcare providers that need to renew their licenses. It's receiving overwhelming response from the medical community worldwide. Since nurses spend more time with patients than doctors, we introduced the first online EDS nursing educational program in 2020. We have 6 programs outlined. We have 3 programs completed. We got delayed due to the pandemic. Many of our speakers for these programs have contributed to this newly released book, Disjointed. We have a book review on our site. Please sign up for our EDS Awareness Monthly newsletter. We introduced this in May 2021 for EDS Awareness Month. A lot of valuable information about research, individuals' particular situations. We just did one on seniors with EDS. So I've listed a few links here to allow you to get to these resources a little easier. All of the slides will be presented on the website, as well as the video recording in the next couple of days. So just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to treatment. For those attending live, there will be an opportunity for Q&A after the presentation. Please add your question and click the submit button. The Q&A will be conducted after the presentation. So again, as I mentioned, Dr. Ross Hauser is joining us this evening. His presentation is entitled 10 Low-Cost Ways to Improve Symptoms of Peripheral Joint and Spinal Instability from Hypermobile EDS, including brain fog, pain, POTS, mast cell activation, and more. Dr. Hauser completed his residency training in PM&R at Loyola Medical Center in Chicago. He obtained his MD from the University of Illinois, Chicago, obtained undergraduate degree from the University of Illinois, Urbana-Champaign. He has authored over 30 medical research papers and clinical results utilizing prolotherapy on a number of chronic pain and musculoskeletal conditions, including EDS, lament, laxity, joint instability, and chronic spine instability. Dr. Hauser has authored 9 books, including Perlo Your Health, Your Pain Away. He has specialized in the treatment of chronic pain, including hypermobile EDS, with regenerative injection therapy, prolotherapy, for over 29 years. So again, we're very pleased to welcome Dr. A. Ross to our webinar this evening, and also his team who organized this webinar in just kind of a different fashion, which I think you'll enjoy. So again, welcome, Dr. Ross Hauser.
I'm coming to you live from the Hauser Neck Center here in Fort Myers, Florida. Just appreciate the opportunity again, John, and the EDS awareness group there. We all know to do something like this, it takes a lot of work. So I just want to thank my media team and specifically you, John, and your team there. Together, you know, we're just continually trying to get the word out that EDS and joint instability is a really serious problem. And again, I'm going to go over how the problems get exacerbated by our modern lifestyle, looking down at cell phones. But I thought for 2 hours, I'm going to go through some easy things that everybody can start doing immediately to feel better. But prior to that, I got to set some groundwork so we're all understanding what actually causes the symptomatology of Ehlers-Danlos syndrome, especially the hypermobility. And then again, we'll talk about what to do about it. I would really encourage anybody who's seeing this after the live session to really watch the whole thing, because inevitably in 2 hours, there's going to be something that applies to you. If you're watching this, it means that you have some symptomatology that just no one's really getting at the root cause. And I often go through stories of patients and different things. So I'd really encourage the person to watch the whole thing. Thank you, John, for the nice introduction. You know, I live in the Fort Myers area. So we have the Caring Medical Florida in Fort Myers, Florida. And then we have the Hauser Neck Center. And basically, the offices are designed to resolve joint instability. And specifically, we utilize a technique of prolotherapy, which we'll talk about. So I'm going to talk a little bit about joint instability and how that causes the symptomatology of Ehlers-Danlos syndrome. These are the offices. You can see beautiful Southwest Florida. And then we do a whole bunch of diagnostic studies in the office here. So in our office, we do motion x-rays. We do cone beam CT scan to specifically look at the 3-dimensional anatomy of the neck. We do transcranial Doppler and other diagnostic studies in the office to come up with the pathophysiology of what leads to the symptomatology of Ehlers-Danlos syndrome and other joint instabilities. I started treating Ehlers-Danlos syndrome soon after I started with Gustav Hemwall in 1993. So I've been a treating doctor for hypermobility and other forms of Ehlers-Danlos syndrome for around 30 years, well, a little bit over 30 years. And I wrote my first information that was published on Ehlers-Danlos syndrome in 1995. And if we think about Ehlers-Danlos syndrome, you'll see that 99% of people with Ehlers-Danlos syndrome hypermobility type have multiple joint pains. 92% have position sense problems. 93% have different kind of hemorrhages. Dystonia is 75%. Gastroesophageal reflux is 72%. Double vision is 74%. Shortness of breath, 76%, dysautonomia, 70%. And the reason why I put that in there, if Ehlers-Danlos syndrome is primarily, and this is the main thing that I keep saying, the symptomatology of Ehlers-Danlos syndrome, most of it is ligamentous. In other words, Ehlers-Danlos syndrome hypermobility type is a ligamentous disease. So if that hypothesis is correct, then these conditions in most people are probably structural in origin and not chemical. So imagine somebody has acid reflux, or they have acidic stomach, or they have stomach issues. Most of the time we would treat it chemically by taking antacids or something like that. But I'm just saying that if the condition is so much more prevalent in Ehlers-Danlos syndrome, it probably has a structural cause, not a chemical cause. So you have to treat it structurally. So you have to align the anatomy, get the curves, the thoracic curve, cervical curve well. And then if there is instability, then you treat that instability with prolotherapy. Now, this is the kind of cases that I see. So Sophia has Ehlers-Danlos syndrome, and you could see their short-term memory loss, postural orthostatic tachycardia syndrome, mast cell activation syndrome. She had gastroparesis, fainting, drop attacks. So by the time I get involved with somebody with hypermobility Ehlers-Danlos syndrome, it normally is a pretty severe case. And I know many of the people watching this, it's not as severe. So many people, many of the symptoms with Ehlers-Danlos syndrome can be treated by the simple methods that I'm going to talk about today. And before we get there, though, we have to lay the groundwork. So one of the groundworks that you hear me say all the time is the collagen. They haven't found a genetic cause yet of a defect in hypermobility EDS. So most collagen that makes up the joints of the human body is type 1 collagen. When you have a genetic defect of these genes of type 1 collagen, that condition is called osteogenesis imperfecta. So now type 3 collagen, type 5 collagen genetic defect is found in other forms of EDS, but the hypermobility form of EDS, they haven't found a genetic cause. And since type 1 collagen, the genetics of it is normal in hypermobility EDS, it basically means that there's some people born with stretched out, weak, if you will, weak ligaments. Just like we know there's tall, lanky people and there's short, stocky people. I'm more of like a short, stocky people. And fortunately, I have a short, stocky thumb. So all the injections I do, my thumb is ideal for doing prolotherapy. So the important ligament information in Ehlers-Danlos syndrome is that type 1 collagen makes up 90% of the collagen in ligaments. That's what gives the strength to ligaments. In Ehlers-Danlos syndrome, hypermobility type, the type 1 collagen, the genetics is normal, and basically the ligaments are stretched out. So instead of being the ligaments being tight like rope, they're stretched out. So they basically need to be tightened. And then this basically shows that type 1 collagen is the collagen in bones, ligaments, and tendons. Type 3 is the collagen in blood vessels, so then you get vascular EDS. And type 5 collagen, so when there's a genetic defect of type 3 collagen, you get vascular EDS, and in type 5 collagen, there's classical EDS. So I put that up there just to note that even in classical and vascular EDS, most of the symptomatology is because of the stretched out, weakened ligaments. So then the bones move in destructive manners. When bones move in destructive manners, that causes symptoms such as pain, such as sensitivity to touch, such as the other symptomatology that we get with Ehlers-Danlos syndrome. So just to go over again, this is a hip joint. You'll see all the ligaments around the hip joint. So see all those ligaments. So ligaments connect the bones. Ligaments can connect the bones. So when the ligaments are stretched out, injured, or weakened, the bones move in destructive manners. And when they move in destructive manners, they cause an enormous amount of pain because the nerve endings in the ligaments, the proprioceptors, and we'll talk about that later in more detail, but those proprioceptors, when the ligaments get stretched, then there's a reflex called the ligamentous muscular reflex that causes the muscles to tighten. And that's why you have so much muscle tightness, muscle stiffness, muscle sensitivity with hypermobility EDS. Now, this just shows that basically all the types of EDS, vascular, kyphoscoliotic, hypermobility, classic, the basic main symptomatology that people have is pain. It's pain. Now, I'm just going to digress a little bit. This drives my media team. But when you look at MRI, so if we did asymptomatic hips, since I had a hip here, asymptomatic hips, do you realize about 70% of asymptomatic hips have a labral tear on the MRI and they have no symptoms? If you do lower backs, it's similar for degenerative disc disease. Like, in other words, somebody has no back pain, they get an MRI of the lower back, they're going to have a problem in the disc, even herniated disc. So if they're asymptomatic, it means that low back pain and hip pain, it has to be coming from something else beside the labrum or the disc. So most of the nerve endings that surround the joint are in the ligaments. And when the ligaments are tight and strong, those nerve endings can't stretch. So when there's ligament laxity, hypermobility, ligament injury, weakened ligaments, then those nerve endings stretch, and that's what causes the pain with movement or being upright. Hilton's law is the nerves that innervate the muscles that move the joint are all the nerves supplied to the skin, underlying joint and ligaments, meaning that a person on the medial side of the knee, they have muscle tenderness, while the nerve that goes to that those muscles, such as the femoral nerve, is going to also be the nerve supply to the ligaments and joint there. Hauser's law is when the etiology of symptoms is elusive, and you guys know this. When you have hypermobility EDS, I mean, it's almost every day I see in the office where the person's coming to see us here, and they'll say, the doctors, they just say nothing's wrong. Nothing's wrong. We don't find nothing. Nothing's wrong. Or they say that it's psychological, where the person knows there's something wrong. Like, I can't think, I'm dizzy, I don't feel right, I have vertigo, I have unbelievable fatigue, right? There's patients that come here and they say 20 out of the 24 days, they have to be laying down. So Hauser's law is when the etiology of symptoms is elusive, follow the neurology. And if you follow the neurology, you'll see that that's going to lead you to ligamentous joint instability as the cause. And once you resolve the joint instability, you're going to resolve that symptomatology. And if you look at joint instability, I know this is a busy slide, but joint instability is what typically causes neuralgia, trigeminal neuralgia, occipital neuralgia. And then we're going to talk about how cervical joint instability can cause vagus nerve degeneration or block impulses to the vagus nerve. And once you have that, you end up having, you can have gastroparesis, swallowing difficulties, and other digestive abnormalities. right? Some of you have small fiber neuropathy. Again, that can be from joint instability. Dysautonomia is rampant in society, not just in hypermobility EDS. And then joint instability is a known cause. Dynamic structural medicine looks at three things, and dynamic means motion. So to show that a joint's loose, you have to move the joint. So if you just do an X-ray, a static X-ray or an MRI, it's probably going to miss the joint instability. There's three components to dynamic structural medicine: alignment, curve, and stability. So if you always remember that, are my bones in proper alignment? Do I have reasonable lumbar lordotic curve, thoracic kyphotic curve, cervical lordotic curve? And then am I stable? So stable means, a stable joint means that the bones stay together pretty much. So in other words, when a person bends forward, right? So if we say this model is a cervical spine with a lordotic curve, when you bend forward, the curve, and then you get back up again, the curve shouldn't be like this. So in other words, this is a healthy cervical lordotic curve, but if you look at your cell phone for 10 hours a day, your curve is going to end up like this. And the problem with that is going to compress the jugular vein, the things in the carotid sheath like the vagus nerve and the glossopharyngeal nerve. And as we'll see later, those things have to do with everything that goes on in the body, and the vagus nerve is the main sensor of the human body. So what I'm talking about mainly is structural cardiology, structural gastroenterology, meaning that there's structural problems in the spine or in the neck or in the thoracic area, and it's screwing up the neurology of the digestive tract, of the heart, of the lungs, and it leads to such things as leaky gut, mast cell activation syndrome, postural orthostatic hypotension. And then, you guys know this, it's just rampant. We see a lot of teenagers with EDS, and they just have a myriad of symptoms. Some of them are almost completely bedbound because ligamentous joint instability is a progressive disorder. So you actually have to do something about it. And I'm going to talk to you about some really easy things that you guys can do about it. And then again, if we look at interventions tried by people with hypermobility EDS, these are the typical things. There's medications, there's nutritional counseling, physical therapy, education, lifestyle modification. And basically, these things are helpful, but they're often not curative. So the things I'm going to talk about today can have lasting effects for the rest of a person's life. And this is what I'm just talking about. When a person with hypermobility EDS has had MRIs and it doesn't find something majorly wrong, it means that, great, you don't have a surgical lesion. Like, that's actually good news. You don't have something that needs surgery. So now you're in the conservative care, and I'm going to explain to you what causes the symptomatology of hypermobility EDS, in my opinion, and then what are some simple things that you can do about it to stop it. And for really severe cases, then you need to consider getting prolotherapy. So the first major point is, to show instability on a scan, you have got to do motion. So you have to do motion. So in our office, we do digital motion X-ray, and some of those digital motion X-rays you can see on our YouTube site, the Caring Medical YouTube site. So I'd encourage people to look at that. And then even if a doctor told a patient that you need surgery, my advice would be is get a second opinion by somebody more conservative. So, like, for instance, today I had a new patient, so they have a 7mm Chiari. Currently, the largest Chiari that we're treating in the office is a 23mm. And obviously, in the future, I'll do more YouTube videos on the conservative care of Chiari syndrome and basilar invagination. And it's not all cases need a surgical stabilization or a craniectomy. And this is one of the ways that we show instability with ultrasound. So peripheral joints, we do stress ultrasounds. You can see here that the medial knee joint in the neutral position, the bones were 4.2 millimeters apart, but on ultrasound, when we stressed the joint, it went to 7.6 millimeters. And you see that there on ultrasound, there's ligamentosis. Ligamentosis is when ligaments become degenerated and they become darker or less dense on ultrasound. So there is such a thing as degenerated ligaments. You might say, well, geez, how does the ligament get degenerated? Well, think about it. If you have hypermobility EDS and the ligaments aren't like rope, they're like spaghetti for a visual. So they're like spaghetti, and spaghetti isn't very strong. So that's why the joint subluxes. So the joint does its best, the ligaments do its best to keep the bones in alignment, because the body doesn't want bones to have destructive motion causing destructive forces, which will break down the joint. So eventually there's too much force on the ligament cells die. When cells die, the cells in the ligaments are fibroblasts. When they die, basically those cells can't make ligament tissue. So then the ligament tissue is less dense, and that's why you get darkness on MRIs or ultrasound. And no, there's two main constraints that you can do something about. You can't do something really about whether your ball joint of your hip joint is very deep or not. There's not something that's something you're born with. But two things you can do something about. One is the musculature, because the muscles help stabilize the joints. And of course, the ligaments help stabilize the joints. So if you have loose joints, think about this. If you are born with loose joints because you have hypermobility, Ehlers-Danlos syndrome, what you need to do is get strong, tight muscles. You need strong, tight muscles. You need strong, tight muscles. So that's one of the points. You need strong, tight muscles, and we'll talk about how to do that. And again, joint instability is a progressive disorder. So if you have knee instability and you don't do anything about, it means that the fibula and tibia bone is moving too much. That will lead to ankle instability. And if your femur bone is moving too much, if you don't do something about it, then you're going to end up with hip instability. So part of doing this is to make sure that you guys do some simple things. And soon I'm going to start talking about those things, but we can never go through the basics again. When you have knee instability, think of this, when you have knee instability, the forces on the joint go massively up. Remember I said my definition of joint instability is that you have excessive movement of the bone that causes destructive joint forces and destructive joint movement, and the treatment that resolves that destructive joint movement is prolotherapy. But tight muscles and muscles that have good proprioception, that will definitely help. And other things that happen is that the forces in the joint get concentrated in one area, and then that area eventually gets degenerated. So this is basically the destructive biochemical changes that occur from ligamentous-induced joint instability. And it's that joint instability that leads to the symptomatology of Ehlers-Danlos syndrome, right? Look at all this. So ligamentous joint instability can lead to spinal stenosis, tendinopathy, recurrent joint swelling, right? If you have joint swelling like in your knee, in your ankle, the body's trying to stabilize the joint. The body has three mechanisms to stabilize the joint. Joint swelling, that'll stabilize the joint temporarily. Muscle spasm, which we talked about. So if you have chronic muscle tightness or muscle spasm, most of the people that I see, they have severe muscle tightness in the upper neck region. That's a sign and symptom of upper cervical instability. And then myofascial restriction, sensitized nerves, neurogenic inflammation, all those things come from ligamentous joint instability. And eventually, if that ligament injury isn't treated correctly, you'll end up getting joint degeneration, right? And this is just another thing. You'll end up getting articular cartilage break down. So you'll get cracks in the articular cartilage, and eventually those cracks coalesce, and then you get loose bodies in the joint, which is basically cartilage flex. And then you lose more and more cartilage. And this is basically shows the degenerative cascade in the spine and the joint. So the root cause of it is ligamentous joint instability. Ehlers-Danlos syndrome is such a challenge because the person has so many loose joints. So an analogy I often talk about in the office is, say I have a stiff ankle joint and somebody with hypermobility EDS has a hypermobile or somewhat loose joint, but it's not yet unstable. But we go hiking and we each get the same little ankle sprain. Well, I might end up, if my ankle sprain doesn't heal all the way, I'll just end up with a hypermobile joint. It just won't be symptomatic. But the person with hypermobility EDS, if they get a little ankle sprain, now the joint's unstable. And then every step they take, they might feel pain because the pain receptors are in the ligaments, and that little bit of extra ligament damage then led to the ligament not being rope-like. It's like spaghetti-like, and now the nerve endings and the ligaments stretch out. Now they have pain with every step. This just shows the common joint instabilities with Ehlers-Danlos syndrome. This is just my opinion, having done this for 30 years. So the lumbosacral region is the iliolumbar ligaments. The hip joint is the iliofemoral ligaments. Those are in the front. The cervical spine, it's almost always the top ligaments at C0, C1, C2. The ankle, it's the lateral ankle, and the knee, it's the medial knee. So ligamentous cervical instability is the structural cause of many diseases, conditions, and symptoms that plague humanity. And then you'll see that what we're going to talk a lot about is comorbidities and what we can do to help and resolve some of these joint instabilities and extra motions. And you're going to be amazed at how simple some of these are. And a lot of these don't cost any money, or it's minimal, and you can do it at home. You can start today. So as I go through these, if you utilize these and they're helpful, I'd really love hearing from you. Because that gives us all encouragement. So for those who don't know about it, prolotherapy is an injection technique that's done all the way down to the bone where the ligament attaches to the bone, because that's the weak link in the musculoskeletal system are the ligaments. So whether you have hypermobility EDS or you're Ross Hauser who doesn't have that, the weak link in the supporting structure of the human frame is the ligaments, and specifically where the ligaments attach to the bone. So prolotherapy goes down to the bone. Sometimes we use ultrasound, sometimes you use x-ray, but like when you do an ankle joint, there's not nerves that you can really hit. So you just, you don't need any x-ray or ultrasound imaging to do the prolotherapy. And again, going to the YouTube site, you can see actually prolotherapy in action. And some of the people with Ehlers-Danlos syndrome that we treat here, they're so extensive that we actually take out bone marrow and use the bone marrow as a proliferant. But in most situations, we just use the common sugar in the human body, which is dextrose D-glucose, and we'll use substances that attract the platelets or the growth factors to the area, or else we'll take out blood and then we'll get the growth factors from the blood. So I'm going to go through 10 easy things that everybody can do to help themselves to relieve the symptomatology and also know what's causing the problem. So number one is do a physical exam on yourself. So any place where there's sensitivity to touch, and normally that is going to be around a joint, or it's a muscle that stabilizes the joint, then that's a sign that there's joint instability in that joint. So wherever there's sensitivity, like for instance, if somebody said there's sensitivity around the shoulder joint, then what the person really should do is exercises that strengthen those muscles that are tender. Like that's actually, and again, if the joint is so unstable, then you have to do isometric exercises. So in like, for instance, like a person could go like that, and all it takes is a 10-second repetition, and you're going to get muscle strengthening. So if I did this for 10 seconds as hard as I could for 10 seconds, and I did my biceps, believe it or not, 10-second maximum repetition, you can get muscle strengthening with that. So usually almost everybody can do some kind of exercise, you know, to strengthen the muscles. And remember, I said you need tight, strong muscles. Then check your pulse. Like the pulse, the normal pulse should be very, very strong. It should be very, very strong. If, in other words, if you can't feel the pulse very well, you probably have low blood pressure 100/60 or below. And obviously, one of the ways to get your blood pressure up is to eat salt. I mean, I'm not going to tell you how much salt to eat, but it's just very, very easy. Like if you have low blood pressure, obviously, I'm going to explain, the next thing I'm going to explain is probably what's causing the low blood pressure. But one of the things to do is just to increase your salt. I live in Fort Myers, Florida. It is a lot warmer than Chicago, and we have to eat a lot more salt here, you know, in our food. You take a tongue blade. One of the things we're going to talk about is low gadgets. You take a tongue blade or something. We didn't film the person today, but I had a patient today. I was just jamming that tongue blade in the back of the throat, and there was nothing. There was no gag reflex. So if you put something in the back of the throat, you're supposed to gag with it. So if you don't gag with it, that's a sign that you have an absent gag reflex. So this particular patient had absent gag reflex. Then the sensory part of the gag reflex is the glossopharyngeal nerve. So this particular patient had glossopharyngeal injury, and the glossopharyngeal nerve, that's the blood pressure sensor, and it also is the nerve impulses for your swallowing muscles. And that's in the carotid sheath. So that's a sign that you have a carotid sheath issue. If you don't gag, then you look with a flashlight and you go, here, is that the next slide? Yeah, so this is a negative gag. Then if you have your uvulas deviated, so you go, and then if the uvula is deviated, that's a sign of vagus nerve injury. And of course, if you have uneven pupil dilation, that's usually a problem with your C1 or C2 is rotated, and it's affecting the superior cervical sympathetic ganglion, which sits right at C2. So again, if one pupil is dilated a lot and the other one isn't, I'd recommend, I'm gonna explain what to do. So if the right one is really dilated, that normally means the right one's dilated. So it normally means that the C1 or C2 is impeding some of the nerve flow on the right side here. So that the C1 and C2 rotates to the right. I'm just going to say this is the right here. So for them to impede flow, it means you're looking to the left. So if you have an upper cervical chiropractor and they're always saying the C1 or C2 is out to the right. So if your right pupil is dilated, or you have tinnitus on the right side, or you have some kind of right-sided symptoms, an easy thing to do is to look to the right. So if it's on the right side, that means your right C1, C2 is rotated to the right. So to rotate them to the left, you have to look to the right. So that would mean that, when you're watching TV, and we'll talk about proper neck position, so which is normally you lift up and then you look up, Then, so if you have right-sided symptoms, you want to turn your head a little bit to the right and just keep that position. And when you're sleeping, you want to turn your head a little bit to the right, right? How much did that cost? Like nothing. So if your thing is always going out to the right, just try to think about, okay, so it's going out to the right. It's going out to the right. That means I'm looking to the left. Could it be that when I'm sleeping, I don't realize it, but I'm turning my head to the left? So all night long, I'm putting the vertebrae in a bad position. So I need to look to the right. So that's just kind of a simple thing. Then let me see. Yeah, get a flashlight. Yeah, okay, so we covered all that. Oh, I'm zooming along. Okay, common physical findings of what they mean. So we said clicking or painful joint means that you need joint instability. And then we'll talk about what exercise you do for that. If you have a deviated uvula, so let's talk about deviated uvula, right? I love deviated uvulas. I have a whole collection of various deviated uvula pictures. Maybe I'll write a book called The Deviated Uvula. Okay, so let's say this particular person, the uvula is deviated to the right. So that means the muscle that elevates the uvula on the right is working, but the muscle on the left is not. Okay, so the muscle on the left is not, and that's innervated by the vagus nerve. Okay, so it's not working on the left. So that might mean that the C1 or C2 is rotated to the left. So it's the opposite of what I just said before. So in other words, when I look to the right, my vertebrae, the top ones which rotate the head, they rotate to the opposite way, which is the left. So that means what I have to do is rotate my head to the left, right? So I would rotate my head to the left. So I might sleep on my side and have my head a little bit rotated to the left. Then I might put my mouse on the left, so I have to look to the left. My children, if I'm a mother, I would have them seated to the left, like when I'm instructing them or eating. Then my computer system, I might look a little bit to the left. So that's how you have to think of that. And those are easy things you can start doing. So it's always what's causing the problem, and is there something that I can do to change my anatomy? So the neurology, again, Hauser's law, I have left-sided tinnitus. Okay, left-sided tinnitus. So what's the neurology of tinnitus? Well, it could be eustachian tube dysfunction. Well, since I mentioned that, go off the grid again. So eustachian tube dysfunction. So let's all do a test, including the people here. We're going to do a test for eustachian tube dysfunction. So pierce your nose, then swallow 3 times and see if your ear pops. So I got a really loud pop on my left, not so loud on my right. So Dr. Hauser has a little bit of right eustachian tube dysfunction. So I have an elongated stylet on my right, which we'll talk about later. And I'll tell you what I do. So you guys, did anybody here did not pop? Okay, so I have a couple of my staff members, it didn't pop. So, okay, so if you have tinnitus and my right ear didn't pop, so that would mean that I'm getting obstruction on my right. I'm getting obstruction on my right. Now I know mine's because of an elongated styling, but if it's from a mal-rotated C1 or C2, that's like looking left. So it means that I have to rotate my head to the right. But if you have an elongated styloid, the recommendation is different, but you have to stay tuned because that's later in this talk. So you gotta know how to keep people interested. Okay, so we talked about, okay, so now extra heartbeats, like if you're having palpation or tachycardia or POTS, that's probably from the left vagus nerve injury. Bloating bowel sounds is the right vagus nerve. Nystagmus, if a person has nystagmus or they have after images or blurry vision, that's almost always internal jugular vein compression. If you have one-sided symptoms, that, remember I said that's probably a misalignment of the atlas for the axis C1, C2. Large pupils, that's dysautonomia. Trapezius tension, that's a good one. So if you have trapezius tension on one side, the trapezius is innervated by the spinal accessory nerve, which is in the carotid sheath. That's normally what causes it. And eye fluttering. And we recently had a patient where she closed her eyes and then her eye flutters. That's normally internal jugular vein compression too. Okay, common symptoms and aggravating factors and what they mean. So again, if you can, I'll have patients who they can move their jaw a certain way and then they get a symptom. Well, obviously, if that happens, the cause of it is something related to the jaw, and normally the cause is joint instability. So this is interesting. So, this is later that we have the TMJ. So I'll talk about TMJ later, but just know if you can move your jaw a certain way and that increases a symptom, obviously you got to do something with the jaw, and we'll talk about what to do. We even have people where they move their arms and they get dizzy. Well, that's normally an arterial vertebral artery or internal jugular vein problem. And honestly, sometimes it's just shoulder instability. So if somebody has really sharp pain in their arm, or they move their arm and they get dizzy, it's probably that there's some kind of vascular compression here, which relates to a shoulder instability. So a real easy thing to do is get a posturific brace or some brace that pushes your shoulder blades back and just see if it gets a lot better. So there's definitely a lot of innovative braces that they now have that we have patients use. And again, if it gets rid of a symptom, then you know that symptom is likely due to the joint instability. Dizziness or POTS, so that obviously being upright, that normally is from vagopathy, which is from cervical destruction or breakdown of the cervical curve, which we'll talk about in a second. These are very, very interesting. So peri-eye pain, or pain that's just horrible around the eye, it's very, very common. And believe it or not, the most common cause with hypermobility EDS is that the person, juts their chin forward, and on digital motion X-ray, we find that the space here, the space between the occiput and C1, it gets very, very narrow. It gets very, very narrowed. And it's unbelievable. If that's you, then what you might want to do is, for like a week, I'm not going to do this. And what I'm going to do is I'm going to be flexed a little. And sometimes you get a brace like the Eclipse brace. The Eclipse brace has a jaw platform that you can flex, because when you flex, it increases the C1 space. So that's a real easy thing you can do. So if you flex, like you have a brace where you're flexed and you hold that position and you're like, man, my eye pain seems to get better. Or you lay down and you're on pillows, you're flexed and that space is increased and you feel better. It's probably you have narrowing of the C1 space because you're doing that. So obviously I'd recommend don't do that. But that, again, that doesn't cost anything. And, often that is very helpful. Likewise, occipital neuralgia, the occipital nerve is a branch of the C2 nerve. So that's the C2 space. So the occiput between the atlas is C1 space. The space between the atlas and the C2 nerve, C2 bone, the axis, that's called the C2 space. So some people, especially those with loose ligaments, when you go like this space gets so narrow, the C2 space here. So it'd be the same recommendations of the C1 neuralgia, just, for a time, a week, Try not to go like that and just see if the occipital neuralgia gets better. Okay, so number one is do a physical exam. I showed some things to do. The second easy thing to do is eliminate variables such as eating, fasting, and see what improves. So a person wonders if their digestive problems are related to food, like do they have a food sensitivity? So my advice would be is go on a juice fast, like eliminate any grains, processed food, dairy, just go on a juice fast for 3 days. Go on a juice fast for 3 days. Don't eat any food and just see if anything gets better. So if body aches get better, because we know that food sensitivities or leaky gut can cause systemic inflammation. But I'm going to show you that if you have a vagus nerve degeneration, which is rampant in the patients that I see, but of course I see advanced cases of hypermobility EDS. But when you have vagus nerve degeneration, you have more inflammation in the body because the vagus nerves, one on the right, one on the left, that's what gets rid of inflammation in the body. So obviously then if you have foods that are increasing the inflammation in the body, if you eliminate those foods, body pain, body aching, even small fiber neuropathy and the symptoms of that, a lot of those things the nerve sensitivity, the tenderness to palpation, a lot of times those things should get better. So I'd really recommend, especially if somebody's feeling terrible, think about going on a juice fast. The other thing about eating, especially people who are suffering from gastroparesis or sluggish bowels, which again is the vagus nerve. The vagus nerve, when you stimulate the vagus nerve, the stomach makes stomach acid, then it increases the contractility of the stomach, so you digest your food a lot better. So if somebody has, especially the right vagus nerve, the impulses are getting impeded, or the vagus nerve cells have died, and a lot of the patients that we see the vagus nerve is like 50% the size of a normal vagus nerve, then the stomach can't digest the food as well. So what you need to do is chew your food till it's a liquid. Chew your food till it's a liquid, because the body, it's much easier for the stomach and the pancreas and the small intestine to break down the food when it's a liquid. So you chew your food till it's a liquid, and then you stop eating when you're 80% full. That would be some simple recommendations. Another thing that a person can do is eliminate excessive destructive joint motion. So you do that by braces, and we'll soon talk about different braces. And if bracing helps, or a cervical collar helps, if you never used a cervical collar, recommend that, and just see if any symptoms get better. Now, every decision you make, everything you see, it takes up brain energy. And one of the easiest ways to feel better is to get off of the internet. Like if you're watching this YouTube video, you need to get off of it and stop, getting so much stimulus from the internet. But I had a high school teacher, a new high school teacher, and I asked her, I said, what's the number one struggle? And she's a career counselor in one of the high schools nearby. And she said, I said, what's the main struggle of the high school kids nowadays? And she said, it's the internet. Like, she said that immediately. And I said, what do you mean? And she said, well, she didn't say the internet. She said the cell phone. And I said, what do you mean? And she said, they're all addicted. She said 100% of the kids in the high school where she's at, they're addicted. I go, like, what do you mean? And she said, I actually checked their screen time. And the average high school kid around here, which is probably also around where you're at, she said the average screen time was 10 to 14 hours per day. So your neck was never designed. You do not have big muscles here, especially if you have hypermobility EDS. You cannot be looking down. You cannot be looking down for hours and hours. So what you need to do is, if you are going to use your cell phone, you have got to get prism glasses and prism glasses have a mirror. So to look down, you actually are looking up. So that would be one recommendation. But if you have brain fatigue, you have brain fog, you're dizzy, you have POTS, the first thing I would do is eliminate all electronics, like just do it. Because every image you see on the internet, you're going to this site, that site, you're playing a game, you're doing this or that, all that stuff takes brain energy. And when the cervical curve changes, so remember I said a normal cervical curve, the curve's not supposed to be like this, and that's what we see. When somebody has this kind of a curve, the blood supply to the brain's all screwed up, and especially the brain drainage is tanking, and that causes intracranial hypertension. And that's what I think causes all this brain fatigue and brain fog. So one of the first things to do is do an internet fast, and that will increase your brain energy. The other thing to realize is every time a person has a positive thought, a happy thought, that gives health to the body. And every time a person has a complaining thought, a mean thought, a bitter thought, an unforgiving thought, it just causes disease. So a person, the sicker somebody is, the more important it is to have joy and to have laughter. Because, anybody who knows me, I do my best, especially in the office here, to get patients laughing, my wife laughing, the staff laughing. And in our house, we have marmalade. Marmalade is a 7-pound, orange kitty that we have. She's like 13 years old now. And honestly, that cat just goes right up to you, lays on your lap, and then you pet her. And it's like you could just see that your vagus nerve is getting stimulated. So that's something everybody should consider. If you're really, really sick, man, have a pet that's going to love on you. And it's hard to not have joyful, happy thoughts when that pet's around you. So again, just to reiterate, it's really important if your brain is struggling to go on a digital detox. And I just told you the story of how many hours per day. Also, drinking some vodka, that helps. No, I'm just joking. No, so, go on a digital detox. And again, bracing. So the brace we use is in the lower back is called the Sorolla belt. I know Dr. Sorolla personally, great guy. And then, of course, this is the Eclipse collar that I talked about, so you can adjust. So if you thought you had C1 neuralgia or C2 neuralgia, put your neck in a little bit of flexion and just see, wearing the neck brace, does any symptoms get better? And again, a million different kind of braces. We've seen all types over the years, and that can provide a lot of symptom relief. And of course, it doesn't. Now, sometimes we get into sophisticated braces like the Cerviguard. The Cerviguard, it pushes your C1 back. So if a person goes like this, they go like this. For some reason, when they go back like this, or something pushes them back, if that makes the person feel a lot better, that normally means that the C1 is too far forward. So you might say, well, why is that? I'm just trying to get it so you can see this. So remember, we said that's the normal curve, but when people use the cell phone now, look at how far the C1 is forward when it's supposed to be like that. So when the C1's forward, it can block the jugular veins, so then the brain doesn't drain good, and that could be even during sleep. And it can screw up the vagus nerve. This is one of our patients who showed us how he is 8 hours a day at work. So obviously that's not good. And this is kind of what it looks like. Just, it's not even close to a normal curve. I coined the term cervical disc structure, which means just broken neck structure. The cause of a broken neck structure is ligamentous instability in the cervical spine, specifically the capsular ligaments. And then when a person gets x-rayed, and we do digital motion x-ray, we can see malrotations. I already talked about malrotation of the atlas or the axis. this particular person, their C1 was 2 to 3 inches too far forward. And this shows that, and you don't have to do digital motion x-ray. You could just at your chiropractor's office say, I want flexion x-ray and I want extension x-ray. And on the flexion x-ray, is there excessive motion of the bone? And the easiest way to stop, because think about this, I said, when the ligaments are under extra stretch, that's what causes pain, right? So when the ligaments, see how the spinous processes here, they're farther apart, so that's going to stretch the ligaments. So what's going to happen to somebody if they have this kind of a curve, and then all of a sudden they do proper posture. Now they have this kind of a curve. The ligaments aren't going to be under stretch anymore. So if the ligaments aren't on any stretch, then the pain's going to go away. So the first thing to do is to get the vertebrae in proper alignment. You do that by not looking down at the cell phone, get prism glasses, then proper computer setup's going to be way, way high. And I'm going to talk in more detail in a few minutes about that. But you basically, you know how most people's computer is here or here, but technically it should be up there. And we have our patients send us pictures of their computer setup. And this just is what it looks like. You can see here, if you look really closely, you'll see that's lines drawn. This person had hypermobility EDS and they just had instability throughout it. Looking down versus looking up. Oh yeah, this is interesting. So see, this is what the spine looks like when a person's looking down, but see when the person's looking up, you can see how they got a much better cervical curve. So imagine if all day long, even if somebody's disabled quite a bit and they're watching TV, but when they're watching TV, they're looking up. So when you have a good cervical curve, that puts the vagus nerve in a relaxed state. So the impulses are more likely to go through, and the jugular vein isn't going to be stretched. So the jugular vein, which is the main drainage port of the human brain, it's going to be more open. So we're going to talk about how to keep your jugular veins open when you're upright and when you're sleeping. So when you're upright, you have to have good computer setup. See, these are some of the patients, some of the staff. Oh, that's Dr. Hauser. So, that's at my house. Oh, that's at my house. Oh, and then I have friends of mine bought me a tripod for my cell phone. So that's me looking at my cell phone. And this is a patient of ours, see her computer setup. So that's what you want to do. You want to be looking up at your cell phone if you don't have prism glasses in your computer. And then some of the people, they can't right away look up. Like it's just, they don't have the musculature. The other thing about looking up is not like this. It's not with your chin. It's a whole body like that. It's a whole body looking up. So you get a core workout. So sometimes you just start with this and then eventually you get the screen higher and higher and higher. And of course, these are people who are soon going to be in my office if they're not already in my office, right? This is what you see every day. It's not good. So in the office, what we do is we do various ways that we correct the curve. I'm giving you just an easy way, which is just, look up, have proper posture, but there are weights that you can do. You see them on the internet. We use the Halo weight system. And then this is a Denner roll, but there's various things that people can sleep on or lay on that they put under their neck, and they end up with a beautiful cervical curve. There's pillows like the Arc for Life pillow. There's different pillows that induce a cervical curve. And this just shows how even just a little bit of curve correction, the spinal canal is much, much better, more room for the spinal cord, and thus the cerebral spinal fluid is more apt to drain better. Hey, try some low-tech gadgets. So I told you a real low-tech gadget is a tongue blade or something to check the vagus nerve and the glossopharyngeal nerve. So a pulse oximeter, that's low-tech. The Eustachi ear device, let me talk about that. So you can get that at Walmart, doesn't cost a lot. So you put it in one nostril, zzz, and then you swallow, and it does help the eustachian tube open. So if you're a person who swallowed 3 times and one of the sides doesn't open, I'd say keep using that Eustachi on that side and try to get the eustachian tube to open. And eustachian tube dysfunction is a common cause of dizziness, tinnitus, and things like that. Obviously, a pulse ox, so imagine if you had a pulse ox on your finger and then you held your neck in certain positions for like 30 seconds. So 30 seconds, then you look at your pulse ox, you do different motions. If all of a sudden you get tachycardic, then you know it's related to your neck. Then going to see an upper cervical chiropractor or somebody who does prolotherapy or curve correction obviously is a good idea. Blood pressure is the same thing. So to diagnose orthostasis, then you just take a blood pressure when you're laying down, then you take a blood pressure and a pulse, when you're upright. So when you stand up, within a minute or two, if your blood pressure drops and your pulse goes way, way up, then that's how actually a person diagnosed postural orthostatic tachycardia syndrome. So you don't need to see a doctor to diagnose that. You can diagnose that yourself. There is a thing called an ear popper or otovent. It's another low-tech device that helps get your eustachian tube open. I guess I'm running way behind. Okay, so we talked about most of that. We talked about the eustachian tube. Then I think everybody should get a heart rate variability monitor. That heart rate variability, that's the best test I think that everybody should get as far as how their health is. So let's just say, because Izzy told me I'm running behind, probably my heart rate variability dropped because now I'm under more stress than I was before and I was really on a roll. But also, when you increase your vagal tone, so say you do exercise and increase your vagal tone, your heart rate variability goes up. So I've done other YouTube videos on heart rate variability, but everybody with hypermobility EDS needs to get an elite or get a, I don't have any association with the elite company. That's the one that I use, the elite HRV, but get some HRV monitor and play around with things that you can do to increase your heart rate variability. The easiest thing is to slow your breathing down. When you breathe 6 times a minute versus 13, your heart rate variability goes way up. That increases your vagal tone. Then the vagus nerve can start working properly. That will decrease episodes of tachycardia, help with swallowing, help with gastroparesis. This is how we in the office document vagus nerve degeneration, because we measure the vagus nerve. So what I would recommend people do is do heart rate variability readings when they're sitting, when they're supine, and then check different, like a person could hold their neck in a certain position, then check their heart rate variability. That will give you a clue as to which vagus nerve is a problem and which neck motion is a problem. Like I had one of our best friends had, whether it was a vaccine reaction affecting the heart or post-COVID, then that's what I did with him. And I could document that there definitely was a vagus nerve issue in him. And then not doing certain neck motions was helpful. Like he was getting all kinds of PVCs and different extra beats and all kinds of things. So I kind of proved to him that it was really related to his neck. And then we're going to work on his neck function. So just know the vagus nerve is really what causes many, many different kinds of conditions in the human body. We use a cardio system in the office So there's lots of portable EKGs. It's the same thing. You put the probe on, then you hold a certain position for 30 seconds, 30 seconds, 30 seconds, different neck positions. And you might be shocked at like the cause of your PVCs or your tachycardia or your arrhythmia, it's the neck. So if it's the neck, then you have to maybe stabilize the neck with a neck brace, see if the episodes go down. Then it may be that if you're still working, get your computer system up again, see if the PVCs or the tachycardia goes down, then it's related to your neck curve and your neck. Okay, so I talked about all those things. I talked postural, orthostatic tachycardia syndrome. Then number 5, to improve your vagal tone. So the optimum lordotic curve improves the vagal tone. A healthy lifestyle, that obviously is a person who practices peacefulness, calmness. So even though I'm in a rush to get this done, I'm going to show you how to practice peacefulness in the midst of amazing stress. Like every second that I'm not going on the slides, I'm getting further and further behind. But no, the point is all of us have stressors, and it's not the stressors that cause the problem. Let's be honest, it's how we react to the stress. So what Marianne and I, my wife and I, try to do is we make our home, we try to just talk about positive things, uplifting things. Most of the things that people talk about that's bad, there's nothing they can do about it. So why are we talking about, the various Russia and Ukraine and the president and all these things? Like there's nothing we can do about it except pray for it, like try to make it a positive. And obviously people who feel loved and give love, they tend to be the most peaceful and calm people. So all of us should be working on becoming a more loving, peaceful person. And this is basically what happens to the vagus nerve. It gets compressed at C1. So if we put our cell phones, or not our cell phones, our computers up and we're looking up, that's going to move the atlas back, and then that'll decrease the stress on the vagus nerve. If you have vagus nerve degeneration, that increases intestinal permeability. That can cause all kinds of irritable bowel, inflammation in the bowel. You can get all different kinds of food sensitivity. So if you're somebody they've told you have a lot of food sensitivities, you probably have a vagus nerve issue. If your vagus nerves aren't working right, the vagus nerves are the sensors for all the mucosal surfaces, basically. So think about if you don't have the defense of your lungs, what's going to happen? You're going to breathe something, and all of a sudden you got all these allergies, you got all this mast cell being released. So if you're somebody who has hives, you have asthma, your lungs aren't so good, you probably have a vagus nerve degeneration problem. So anything to help the vagus nerve is going to help. And this just shows a mast cell that's degranulating. So definitely a lot of ways to improve your vagal tone. Obviously being calm, laughter is just great. So there's many times I look at YouTube, when I'm very careful on how much computer time I have, because I don't want to be somebody who says what you're to do and I don't do it. But when I do it, I'm just trying to find funny videos, because every time you laugh, you're increasing your vagal tone. Pets, prayer, Bible reading, slow paced breathing, uplifting, encouraging friends. You should play around with music. So you're going to see that most of the music that you play, it's actually increasing your stress. Your HRV goes down, it doesn't go up. So play around. Like for me, Beethoven, Pachelbel, Andrea Bocelli, those are the things that increase my vagal tone, even though I do like Motown and different things like that. But usually anything with drums, that's going to increase your sympathetic tone, not your vagal tone. Unclog your brain, right? So there's so many neurologic and psychological symptoms that are reported in intracranial hypertension. So blurred vision, headache, double vision, eye pain, photophobia, tinnitus, tunnel vision, depression, depersonalization, aggression, anxiety. All these things can be caused by increased brain pressure. And increased brain pressure, in our experience, it's because the jugular veins are getting blocked. The jugular veins are getting blocked because of destabilization of the cervical spine and the forward head posture, looking down posture that we all do for hours and hours a day. So the first thing is stop all that. You're not going to look down anymore. And then you're going to try to induce the cervical curve. We talked about inducing the cervical curve with your computer setup, but soon I'm going to talk about sleeping position. And this is what we do in the office. We just do ultrasounds with different positions, and we can tell definitively which positions are obstructing the jugular vein. And when you don't have brain drainage, guess what's going to happen? When your brain can't drain, especially at night, and sleeping is for cleansing and restoring the brain. So say that with me. Sleeping is for cleansing and restoring the brain. Sleeping is for cleansing and restoring the brain. So what's going to happen if all night long, if you guys don't cleanse and restore the brain, what? You're going to get brain fog, depression. I don't feel like myself. I can't think. You're going to get more irritable because your cognitive function isn't so good. So you have to drain the brain during the night. That's the most important thing, drain the brain during the night, because you have to open up the jugular vein, which is the main drainage port. And ligamentous cervical instability is one of the main reasons that I believe that people have increased intracranial pressure, along with a whole bunch of other things. So how to plunge the brain so it drains, right? Because if it doesn't drain, basically you're going to get a toxic brain, and you're going to have neuron poop or neuron waste products just accumulate in the brain because there's no way for the brain to drain. So you have to have the proper sleep position. So we're soon going to talk about that. You correct the cervical curve. Are the styloids blocking your pipes? Optimize computer setup, look up. So let's just talk about the styloids. Now, the way you diagnose whether you have large styloids is a CT scan of the neck. So if you have like a lot of odd symptoms and nobody can figure it out, and you don't think, like, in other words, you go to a chiropractor and the curve's pretty good, and you're like, and then you still have some horrible symptoms, brain fog, vertigo, all kinds of things, swallowing difficulty, look for elongated styloids. So what we do in the office here is cone beam CT scan. And then this is what it does. It blocks the jugular vein. It blocks the jugular vein. So I'm going to show on a model. I know this is a little bit hard to see. Okay, here, I'm going to put it here. Okay. So can you see that or not? Okay. But this has a styloid here. So the styloid is going to block the jugular vein from the front. So if the person flexes, if you're somebody who flexes, or you sleep on your back and you flex, and that position is horrible, you probably have an elongated styloid. The styloid bone is never supposed to go. The styloid bone is never supposed to go to the atlas. This is a cone beam CT scan. It's never supposed to go to the atlas. So if your styloid goes to your atlas, it has the potential to, with flexion or rotation, it can block the jugular vein, can block the vagus nerve. The vagus nerve and the jugular vein go through the same hole to the brain, which is the jugular foramen. So the method, think about this is interesting. I know some of the things I said isn't so interesting, but this is interesting. So the interesting thing to me is to open up the space. So the space between the styloid and the atlas, that's called the atlantostyloid interval. The way to open up the space is what? Is to look up, is to have a normal lordotic curve. So isn't it interesting? The same method to get rid of vagus nerve degeneration, block jugular vein, and styloid is to have proper neck posture. So that's the same thing. So is my jaw part of my systemic symptom? So there's certain situations where I can move my jaw in a certain way, and then I'll get tinnitus. So give you an example. So I recently had a crown, my first crown on my right side. I was doing really, really good. And for about 2 weeks after that crown, because, to get the crown done, I had to have my jaw in a goofy position for an hour or 2 hours. All of a sudden I had tinnitus and all kinds of things because I then stretched out my TMJ ligaments. Now it's healing on its own because I just had this about 2 weeks ago. But if it doesn't, I'm going to get some TMJ prolotherapy. So this just shows ways to figure out if the jaw is an issue. Give you an example. You can have your pulse ox on, you could have the cardio on, you could have a HRV on, and just move your jaw in certain ways. And then you can see if you have any symptoms. Right. The other thing too is do a physical exam. So we're just going to look at one of our patients here, which is Izzy. No, it's okay. Oh, okay. No, it's okay. So long story short, so if you open up your mouth and your mouth goes crooked, that's obviously a sign that you have a jaw problem. Then if you look on the side and you open up and the jaw pops out, that's another sign that you have a jaw problem. That's okay. Okay, so I'm going to go, just because we have limited time, I'm going to talk about sleep position. So remember I said that what you want to do is be looking up with your computer, Okay, so we're there, that's fine. When you're looking up at your computer, so looking up at the computer, it induces the cervical curve. So it induces the cervical curve. You can induce the cervical curve with sleeping. So if you have right-sided symptoms, we found your jugular vein opens up and your vagus nerve isn't so stretched if you sleep on the side of your symptoms. So you sleep on your right side if you have right-sided symptoms. And then instead of looking straight, you look up at the back wall. So you look up at the back wall, and that induces the cervical curve. So I would advise people to try that. Sleep on your side, looking up at the back wall. And then if you have really, really severe symptoms, I would recommend do that 5 minutes every hour. Even if you're working from home, that's going to help your brain drain. And it's more likely that the vagus nerve is not going to be under stretch in that position. So 5 minutes every hour, lay on your side, look up, and then the other 55 minutes, probably your brain function is going to be better, and then you'll have less symptoms. So what we do in the office here is we might check how the neck is being affected by the jaw by doing cone beam CT scans. And you could see, the person here has different jaw positions. And then of course, we get a whole readout on the neck. So this is Karina checking the jugular veins in the person with different sleeping positions. Then we find the very best sleeping position. So that's the position. Remember I said where you're laying down, but you're looking up instead of looking straight. And then sometimes we have the people rotate their head, but a good place for people to start is just laying on your side and then be looking up. And then of course we can also have them on their back, and we could check the neck x-ray to see if their spine's in really, really good alignment. The proprioceptors, the motion sensors are in the ligament. So proprioception is doing balance work. Anybody can do some balance work. So people who are really, really weak, I have them like in their kitchen, the countertop, you could be right there, and then you just do balance work on one leg. You do balance work on one leg. This just shows the motion sensors are in the ligaments. And then probably the best overall exercise is just standing, and if the person's able to, is mini squats, just mini squats. So if somebody had, this is a bar stool, right? So I could probably just go like this, go like that, go like this, go like that. And then balance work would just be balancing on one leg. So again, a person could be watching TV, just standing instead of sitting. I could be doing my notes at the end of the day, and I could just stand on one leg, and be doing balance work there, just doing my computer work. So again, proprioception or doing exercises that have to do with balance is a great thing that's easy to do. This is the last thing. Number 10 is hormone deficiencies. So with hypermobility EDS, I find that their hormonal system is really often low. So I'm going to just show a couple of cases. So if you look at hormones play a role in collagen repair and brain swelling. So testosterone stimulates fibroblastic proliferation or ligament tightening. Estradiol inhibits it. So again, ligament laxity is more common in females than males. Testosterone is the male hormone. So these are the ideal levels. That recently I had a hypermobility EDS patient who was doing great. She got her menstrual cycle, was doing terrible during the menstrual cycle. So I said, the next time you do that, let's look at your hormone levels during the time where you feel terrible. And basically what it was she was missing progesterone. Progesterone is amazing to reduce brain inflammation, and it has a lot of positive effects. That'll be the next slide. Then hypermobility EDS patients that I've seen that spend most of the time in bed because they're so disabled, normally all their hormone levels are low. So sometimes we use hormone replacement to stimulate appetite, increase muscle mass, and then you just have to, because even if you do prolotherapy, which stimulates proliferation, if the hormones are so low, they're not going to proliferate that much. So progesterone has many potential benefits on the brain. So if you're a female and you know that with your menstrual cycle, it's a nightmare, the symptoms get way worse, you're probably missing progesterone. So it's very inexpensive to get on a little progesterone. Progesterone is neuroprotective. It stabilizes the blood-brain barrier. It decreases cerebral edema. It decreases brain inflammation and improves the brain's ability to repair itself. This just explains that catabolic physiology is where the testosterone, DHEA, and pregnenolone are high. The person's in a growing phase. Anabolic, it's in an anabolic state. Catabolic state is breakdown, and that's normally where the person has estrogen dominance. There's too much estrogen, not enough progesterone, DHEA, testosterone. So when you have ligament laxity, you actually want your more male-like hormones, testosterone, DHEA, and pregnenolone to be high. So that might be easy tests that everybody could get, with your doctor. And this just shows that estradiol, if it's too high, it's going to inhibit the body's ability to repair ligaments. This just shows that the main quality of life issue in many people with hypermobility EDS, it really is it's fatigue. It's just overwhelming fatigue. And I'm just telling you, if you have overwhelming fatigue, it may be due to brain fatigue and or physical body fatigue. Physical body fatigue often is that the hormone levels are low. Brain fatigue is normally that the brain isn't draining good, and that's because of jugular vein compression and the person is on the internet too much. So brain fatigue, do the proper neck position, limit the time on the internet, don't look down. Body fatigue, obviously, eat proper, healthy, nutritious food, take some vitamins, get under the care of a holistic natural medicine provider, and then check the hormone levels. And I like this one because it just says positive therapies that assist each other resolving the sequela of EDS-induced joint instability. And you'll see here, proper workstation. We talked about proper diet. We talked about reading positive things, visualizing good things happening, soothing sounds, natural hormone replacement, isometric exercise or low impact exercise, passionate work. Think about this. what's the most significant thing a person could do in life? Like, what's the most significant thing Dr. Hauser could do or you could do? Like the most impactful, beneficial thing you can do. And we could have a good discussion about it. But if we're honest, it's loving God, loving yourself, loving others. And part of that is praying for each other, right? If we think about it, and anyone can do that. So the most significant thing that we all can do, you don't have to have maximum energy to do it. You don't have to be physically fit to do it. Probably the most significant thing we can all do, honestly, is pray for each other and call each other and talk to each other and all that stuff. And I'm just grateful for the EDS awareness group. I'm grateful that my patients can connect with others on the internet to encourage each other. I mean, it's unbelievable the stories I hear. I hear of friendships starting just by encouraging each other. Sometimes in the office, I even introduce EDS patients to each other, and some of them I know they've had lifelong friendships. So I'm going to stop here and take questions, and I just really appreciate John and the group there for giving me this opportunity to talk. Thank you guys so much.
One of the first questions was, what type of testing do you do to get the hormone levels?
Oh yeah, what type of? I like blood levels. I like blood levels. So on that slide, we'll put that slide on the internet. But no, get blood levels. So you want your blood levels of testosterone. You know, blood testosterone as a gal, you want it over 50. The DHEA, I would say at least over 200, at least over 150. Then pregnenolone over 100. So those are blood levels. And you'll see that if you check your progesterone level and you're having a lot of PMS or the menstrual cycle increases your symptoms, you'll see that your progesterone is very low. So getting on some progesterone is going to help a lot. Oh, prolozone versus prolotherapy. So ozone is definitely a proliferant. It's not as strong as the other proliferants, but if somebody had a little bit of a joint problem, prolozone is going to help a lot. But by the time I see the patient, ozone is one of the proliferants we use, but it's not the main one. Obviously, the strongest proliferant they can inject in a person is going to be like bone marrow or fat. Second strongest is likely going to be PRP. And then we also use various substances like hypertonic dextrose to induce healing reaction to tighten and strengthen ligaments. So that's, if you think about it, prolotherapy causes the resolution of the destructive joint motion of joint instability. So it resolves joint instability. What causes clicking, popping? So no, it's honestly, it's ligament incompetency. It's ligament injury, lax ligaments, whatever you want to call it. It's actually the bones rubbing. It is the bones rubbing. So, and if you guys are always doing this, just know every time you do that, you're making your joints a little bit looser. So even before getting prolotherapy, you got to get out of that habit. So I recently had a patient where I kind of made them wear a brace for a while so they get out of the habit of clicking or self-manipulating before prolotherapy, because you can screw up the prolotherapy, and prolotherapy tightens and strengthens the ligaments. Can loose hip ligaments cause avascular necrosis? You got it. Yeah, that's a great question. So when your MRI shows cysts, subchondral cysts, when it shows bone marrow edema, it shows modic changes in your spine, or you have avascular necrosis, it's because of all those things are because there's too much pressure on the bone. So what's causing too much pressure on the bone? I showed you with the knee figure that when you have joint instability, the forces on the joint go up drastically. So if the forces go up drastically and you have a ball in a socket and you have joint instability, and every time you take a step, it's bang, 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 bang. Eventually, the ball isn't a ball anymore, and you get collapse of the femoral head and you get avascular necrosis. So the cause of avascular necrosis, as it is a lot of conditions, again, use Hauser's law, you have avascular necrosis. So what's the neurology of it? Well, the neurology of it is the nerves are in the ligaments. So what causes those ligaments to stretch out? Well, that's going to be hip joint instability. So if the ball is still a ball and a person has avascular necrosis and they have some range of motion, you can use prolotherapy to resolve the pain. If chiro won't hold, can prolotherapy hold it? Yeah. If you ask really good chiropractors know about prolotherapy and you said, when you would refer for prolotherapy, they would say, when you no longer hold the adjustment, like in other words, you're needing more and more chiropractic care to put the atlas in or to put the knee joint in or the low back in, then you have to get prolotherapy to tighten the ligament. So it's going out of joint because of ligament injury. PRP versus prolo, heard you must do PRP. No. A lot of our patients, we just do regular prolotherapy. PRP is good, but the problem is it like doubles the cost of the treatment. So there's lots of people where we just do prolotherapy. Realize it's all prolotherapy in a sense. Prolotherapy is the technique of stimulating the ligaments to grow. So if you're going to get any regenerative joint injections, make sure that the doctor is going to do your ligaments. The most important shots to get are into the ligaments, not into the joints. So next. Small exercise to help healing. Oh, healing of the hands. Yeah, that's really good. You know what I do is I have patients take a rubber band. Again, we're trying to talk about low tech things that are free. So I have them just take a rubber band and wrap it around the ends of the fingers and just go like that. Yeah, we don't have you just go like that. You just wrap it around, and that honestly, it works really, really good. Oh, low histamine diet. Yeah, it's interesting. There are people that have diamine oxidase deficiency. The test for that's a little bit tricky to get. Like, you have to get a special kit and da. So there definitely are people that have a histamine breakdown issue in the gut. But Dr. Hauser's opinion is the histamine flares of mast cell activation syndrome are primarily because the neurology of the lung and the bowels is not there. Let me say it a different way. The vagus nerve degeneration causes leaky gut and leaky lung. So think about what leaky gut is. It means that food particles are getting exposed to places in the body that they shouldn't have because the tight junctions in the bowels now are like this. Well, what would happen in the lungs if the integrity of the mucosal surfaces was breaking down because of vagus nerve degeneration? Then all of a sudden, the defense mechanism, the mast cells in your lungs and in your digestive tract, they're going to get exposed to so many things. So the mast cells and the other immune cells that line your bowel wall or line your lungs, they're like an army, because how can a human being get sick the easiest? How can a human being get really ill from COVID, right? Like how? It has to enter a port. So it enters the lungs or it enters the digestive tract by food. So imagine if the mast cells in the lungs are getting exposed to so many things that it shouldn't because the mucosal integrity is broken up. You're going to get all this mast cell release that wouldn't happen if the mucosal surfaces were intact. So Dr. Hauser believes that the real cause for most people, it's a structural issue, not a chemical issue. If we strengthen the vagus nerve, and we haven't even talked about vagus nerve stimulators, right? You can go on Google and get some vagus nerve stimulators. So that's another thing you could do that doesn't cost a lot. Like you could do vagus nerve stimulation in the ears and do it many times during the day and just see that if I have mast cell and I do vagus nerve stimulation, if it gets better, It's again, Hauser's law, follow the neurology, the vagus nerve runs right on the anterior cervical vertebrae. Then if I get my cervical curve better, maybe my mast cell activation syndrome will stop. So I definitely had patients where POTS is gone, mast cell activation. And I'm not saying I cure every single person, but I definitely can tell you that it's possible to permanently resolve it. So I'm telling you that can happen. Okay. Eye pressure pain, grinding cause.
What's the cause?
Oh, what's the cause of eye pressure pain? Okay, so in our office, we do intraocular pressure measurements. We do pupillary light reflex readings. We do optic nerve sheath diameter. So eye pain, I said one cause of eye pain was C1 neuralgia, and that occurs because the C1 space gets narrowed. Another cause is intraocular pressure going up. The normal cause of intraocular pressure going up is just the jugular veins aren't draining. When the jugular veins don't drain, the pressure inside the brain goes up. Then the eye gets squished from the back. It's called posterior eye squish. It's a real thing. You get flattening of the posterior globe. It's a known issue with intracranial hypertension that increases the eye pressure. So the treatment is just like what I said, is get the cervical curve good. If there's instability, then of course consider getting prolotherapy.
Do EDS patients have dry eyes?
Oh, do EDS patients have dry eyes? It's interesting. That's not a common thing that I see. I mean, I definitely have seen it. What causes secretions, what normally causes secretions is vagal nerve stimulation. So anytime somebody, like their pancreas isn't making enzymes, or the stomach isn't making stomach acid, or the thyroid isn't making thyroid, right away, using Hauser's law, I think of the neurology. So again, I think vagus nerve. So I think vagus nerve. So again, vagus nerve stimulation, check your HRV because that's a really good measure of vagal tone, and increase your HRV or do vagus nerve stimulation, do all the things to get your cervical curve better and see if the secretions come back in the eyes. Now, a person could have Sjogren's syndrome or some autoimmune disease that's destroyed the lacrimal glands of the eye, then, vagus nerve stimulation may not do anything. But most people that I see, and again, it's not a common thing that I see, but when I have seen it, we definitely have had patients where they've gotten restoration of their, secretions of their eye. Which one? I'll recommend soft colors. Yeah, remember I said one of the ways to figure out what's wrong is to limit motion. So I definitely would recommend, doing a neck collar. Now, part of the problem could be why we recommend the Eclipse collar versus just a normal soft collar, but you definitely could try a normal soft collar. Sometimes people put soft collars on tight, and it actually causes, compression of the jugular vein. So, be careful of how tight you put the soft collar on, because that could compress the jugular vein. But definitely stabilize the neck with a collar and see if any symptoms get better. Oh, long-term studies on prolotherapy, does it increase arthritis? Okay. Remember I said the cause of degenerative arthritis is joint instability. So prolotherapy done correctly and well, it should stop the arthritic process. So the way we document in our office whether the prolotherapy is working or not is we do motion x-rays. So remember I said with the knee, we would do ultrasound scans. So you could tell by ultrasound scans whether the joint's tightening. Then we could do digital motion x-rays and we could tell whether the neck ligaments are tightening. So that's how we do it. Then if you go to caringmedical.com, we have all kinds of our studies. We have our studies on prolotherapy. If you go to PubMed and you type in prolotherapy, there'll be all kinds of studies on prolotherapy. So our office, like I said, I've done about 30 studies on prolotherapy. So the results are there, and it works really good for arthritis. And we have in most of our studies, when we've looked at, have we stopped somebody to do surgery? I'll just give you an example. In 2007, we followed 34 patients that came in a row that were told that they need a surgery to resolve their issues. So I assessed them and they were good prolotherapy candidates. At the end of the time, like a year, only 3 of them needed surgery. So we had a 90% success rate with hips, knees, meniscus, different things that they didn't need a surgery after getting prolotherapy. So that's why I recommend, if you've been told that you need a surgery to resolve it, because I'm getting consultations of people that have been told they need craniectomy and upper cervical fusion, because it's such a drastic operation. So I definitely think a skilled prolotherapist is a good thing to do, so you can see whether or not there's another option besides surgery and craniectomy. Oh, do you need adjustments before prolotherapy? We do have a chiropractor in our office too. You can usually tell whether there's misalignments, but always know with prolotherapy, if somebody's like this and you tighten the ligaments, it goes like this. If somebody's like this and you tighten the ligaments, so you don't necessarily need adjustments before prolotherapy. Some people have such major misalignments that we do recommend they get adjustments before prolotherapy. Most people don't. Does ear redness indicate vagus nerve issue? There's like 4 nerves that innervate the ear. So ear redness can be a lot of things. It can even be an autoimmune disease. It can be a vagus nerve issue. It can be a C2 or C3 nerve issue. It can even be a trigeminal nerve issue. So there's many nerves that go to that area, but it all relates to the neck. So again, I would, in that situation, if that's you, I would do all the things that we talked about here. And if you didn't get resolution, I would probably go to an upper cervical chiropractor and have them assess you and see if there's an upper cervical issue. Can you sleep in a neck brace? Honestly, normally we don't have people sleep in a neck brace unless it's clear that they just can't stay in one position. So I would say try to get used to being on your side, play around with right side, left side. But if you have right-sided symptoms, sleep on your right side with your neck up. And if you just go all over the place, of course, you could use a neck brace, but just be careful that the neck brace doesn't constrict your jugular veins. How to progress to sleeping with head up? For some, this is difficult. No, well, what you do is then all you do is sleep on your side, and just, if you have to keep your neck neutral. So what you might do is you actually might stick the chin out a little bit. So in other words, you're not looking out, but just, instead of like you're on a pillow and you're like that, you might just be here and just stick the head out a little bit. Maybe just start with that. Remember, I said, if you have really severe symptoms, make sure you lay down 5 minutes every hour. Oh, best pillow to use. There's a million things. So I can't I'll just tell you one other thing. So another thing to do is you can put towels or something underneath your neck. Like if you don't want to sleep on your side, you could sleep like this, right? Again, I'm inducing a cervical curve. Like you can put something underneath your neck. So like I said, there's Arc for Life pillows. Everybody's neck anatomy is different. So you just got to play around with it, and you got to just try to induce that curve. So, and sometimes some people just do best with towels underneath, or like I have a specific kind of blanket. So a lot of times I'll just put that blanket around, because some nights, you just don't want to sleep on your side. So early onset osteoporosis and EDS, how to treat. So remember I said that often with hypermobility EDS, your testosterone, progesterone, DHEA, and pregnenolone are low. Well, guess what those things do? They build bone. So that's why if you think you're starting to get osteopenia, which is low bone density, or osteoporosis, which is really low bone density, then get your hormones checked. So as a natural medicine doctor, how I treat Osteoporosis is I use natural hormone replacement, then I give supplements like bone builder packed by orthomolecular, that I prescribe things like that. To build bone and to not get osteoporosis, the bone has to feel muscle contractions. That's where if you're not active or you're not standing, remember I said probably the best exercise is just standing. So let's be honest, when we're working on the computer, we'd be better off standing and have our computer up. So standing, watching TV, like stand. So that muscle contraction, if you don't have a lot of muscle contraction, even if you have good hormones and nutrition, you may still get osteoporosis because you need that pulling on the bone to keep the bone density good. Oh, prolotherapy or costochondritis or inflammation or slipping rib, it works very, very good. So definitely if you got basically any clicking joint, any painful joint, normally prolotherapy is very, very effective at resolving the pain. Oh, how to treat tinnitus. So the two causes that we see for tinnitus is either eustachian tube dysfunction. So I did talk about that. And then the most common cause that we see is obstruction of the carotid sheath, specifically the jugular vein. It's the jugular vein. So all the things I talked about to open up the jugular vein, that should help with tinnitus. So do the eustachian or the ear popper or the swallowing to try to open up the eustachian tube. Sometimes the eustachian tube isn't opening because of food sensitivities. So the most common food allergens, of course, are gluten and dairy, because that's what people do a lot. So you might want to try a gluten-free, dairy-free diet, get on a really pristine diet, do all the things I talked about, get your HRV up, get in positions where your neck curve's good. You optimize your neck curve, and you might find in the next month, 2 months, the tinnitus really starts getting better. Oh, optimal testosterone in male with EDS. Yeah, I didn't, I definitely have males that have Ehlers-Danlos syndrome. So if you look at Dr. Hauser's chart, I almost brought my chart. So you would know that early on when I first tested, when I'm in my 30s, my testosterone level was over 600. Then I started biking a lot, and biking, bam, 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 bam on the testicles. Then my testosterone level went down to the 300s, early 300s. So I did for a while use some testosterone. So I haven't been on testosterone myself for 8 years, 10 years, 12 years. And if you check my chart, you'd see that, geez, Doc's he's 59, doesn't look too bad. Still runs, bikes, swims, and my testosterone's over 600. So, and then I'm not on any supplements. I'm not on any natural hormone replacement. I take supplements, but not hormones. I don't take any DHA prenol. So I just do it naturally. But I would say you want to be probably over 500 optimally for a male. And like I said, for a female, I'd say over 50. Yeah. Sudden hearing loss, is it associated with CCI, and what's TM? Okay. TM, okay, tympanic membrane, okay. No, so, sudden hearing loss, there's a lot of different causes. So the first thing I would think of is there's eustachian tube dysfunction. So if there's, so I would just ask the person, if they swallow, does the ear pop? So if the ear doesn't pop, then you're thinking, well, they have eustachian tube dysfunction. So it's all the things I said. The other thing too is with a Q-tip, if there's water in the hearing loss ear, like there's water, like right now, remember I said I had a crown and I got issues here. So like this ear, there's no water in it. This one, there's a little bit of water. I can even hear it when I go like this. And then if I do this, then like right now I can hear a little bit better. So just by me doing that, my eustachian tube drained a little bit better. So if there's water, that's normally eustachian tube dysfunction. The other thing too is that when you have increased intracranial pressure, you can get CSF back up anywhere. Where we measure it is the optic nerve, which is cranial nerve 2, but the hearing nerve is cranial nerve 8. So I think part of the hearing loss that you see with CCI is blockages of the vagus nerve on that side. So I would ask the person, why don't you see if your jugular veins open, or at minimum do all the things that I said to open up your jugular vein. And then sometimes atlas misalignment can block the CSF. So again, getting some upper cervical adjustments is a good idea. Oh, how long does prolotherapy last with the EDS? Yeah, it's another great question. Like obviously there's patients I treated years ago, I've never seen them again, and it lasts for good. So it's designed to last for good. A lot depends on though if we have good posture or not. So imagine I treat somebody's neck and then they go back to 5 hours a day like this, like, you know, it's the ligaments are going to be lax again. But if you maintain good posture and good musculature around the joint. So say somebody does the shoulder joint and they feel good and they do reasonable exercises that strengthen the musculature around the shoulders, there's absolutely no reason why the pain and disability should come back. So appreciate all your questions. How we doing? Insurance coverage for polo, why not? Oh, why not cover it? Sometimes insurance companies cover it. Most of the independent insurers, like the Christian insurance companies, what are some of them? Medishare, Christian Healthcare, they definitely cover prolotherapy. So that if you want to know what kind of healthcare coverage I have, I do Medishare and other, you know, I like the independent insurance companies. So some of them absolutely cover prolotherapy, and obviously there's patients that fight for coverage. Medicare currently doesn't cover prolotherapy, so some of the insurance companies follow Medicare, but yeah, some of them absolutely do cover prolotherapy. So I appreciate all your questions. Nerve compression in EDS, yeah. Most of the nerves of the body run within 2 or 3 millimeters of the bone. So when we talk about the vagus nerve, 2 or 3 millimeters in the bone, the spinal cord is encased in bone 2 to 3 millimeters from the bone, the ulnar nerve 2 to 3 millimeters from the bone, median nerve. So when you have hypermobility of a joint, it's more likely that the bone is going to move in a destructive manner to compress or stretch a nerve. When a nerve gets stretched or compressed enough, it injures the nerve. So if you have ulnar neuropathy or median neuropathy, or you have hypermobility EDS, and you've been told that there's a nerve that's irritated or stretched or compressed, again, Hauser's law, it's probably some type of ligamentous joint instability that's causing it. So I'd recommend prolotherapy or some treatments designed to stabilize the joint than some type of nerve treatment or surgery to remove the compression. You just have to stop the destructive motion of the bone. Once the bones move in a normal manner, the nerve irritation stops. Thank you again for all the questions. Blood pressure issues in EDS. So the first thing I do is do the tongue blade thing and see if your glossopharyngeal nerve is working or not. Because you always got to remember the glossopharyngeal nerve is the sensor for blood pressure, just like the vagus nerve is the sensor for the internal organs. So if your sensor is not working, that of course could give blood pressure issues. So we see both hypertension and hypotension. So we actually see both. So the treatment normally is designed to correct the cervical curve. So even what all the things I said today, ways that you could correct your cervical curve, it might improve the blood pressure issues that you're having. And you can test it at home. You can check your blood pressure right when you're sitting. Then start doing all the things that we talked about here, like improve your cervical curve. And the chiropractor or a local provider can do a lateral C-spine x-ray. Anyone can get it to see where you're starting, improve your cervical curve, and just see then again what happens with your blood pressure. So that would be the first place to start. Sometimes, obviously, I got to get involved with prolotherapy to the neck to stabilize it, to help with blood pressure. But yeah, we have people where the only cause that we can think of for their blood pressure is cervical destructure or a breakdown of the cervical curve.
This is the last one.
Okay, last question. What? Oh, okay. Okay, so can exercise for those who cannot,
Core exercise.
core exercise for those who cannot put screen up. Oh, core exercises for those who can. Always remember, anytime you contract, like I'll give you an example. If I go like this and I just have the screen here, like if I raise my chest, I'm doing a core exercise. When you squat like this, that's a core exercise, the butt exercise. So basically, the simplest thing I think for people to do is just keep your chest up. You can be on a chair. You could be, I could be looking down at the screen right here. Like I'm looking down, I'm doing a core exercise. This is contracted. I could feel my lower back contracted. Like when you slouch and you're like this, you're putting your neck in flexion and you're putting your lower back in flexion. That stretches all the ligaments. The number one cause of chronic low back pain and chronic neck pain is just slouching. So when we go like this and you raise your chest, so the easiest thing to do is just raise your chest. Anyone can raise their chest. Sit in a chair, watch TV. So just that's the easiest thing. If we all just did that, we would, we wouldn't need to go to the gym and do planks and everything. And obviously, planks don't involve any motion. So obviously planks if somebody's able to, but if you're really weak or disabled, man, you can just start, but again, you might not get muscle building like you should if your hormones are low. So then again, you might want to get your hormones checked. But again, John and the EDS awareness just really appreciate, you guys letting me talk. And I hope this won't be our last time. And I appreciate you giving me all the time that you did today. Thank you, everybody.
Thank you, Dr. Hauser. And I'm going to have to listen to this at least 3 more times. There is so much good information here. And I was trying to follow it, and you went from one to another. And I think a number of these things will be very helpful for my daughter, who's actually struggling with everything, hypermobile, EDS, and POTS, and mast cell. So I think this is going to be a valuable resource for people that have many of the different conditions associated with EDS. So thank you again. We will get this posted. We'll get the slides posted in the next few days, and really appreciate you coming back again to visit with us. So
Thanks again.
Have a good day. Thank you. And all the attendees, really appreciate the questions and the attention, and everybody hanging in there. And we will talk again. So have a good evening. Good night.
Good.